Thanks, Nishant, and thank Rod and Rishi, my colleagues, for sparing their evening to participate in this, and certainly to all the fellows who have also joined in. So, the subject that we're going to talk about, catheter ablation of papillary muscle ventricular arrhythmias, it is one of those subjects that has kind of become a little bit more interesting just because there are more and more cases that we are seeing of this particular arrhythmia. And so while a lot of the concepts that we use in cardiac electrophysiology, idiopathic ventricular arrhythmias apply to this particular group, there are certain unique features about this subset, which we'll get into. So what I thought I would do is, maybe start off by talking about some of these questions that I've put together to see what our background knowledge is of the group here, and then we'll build on that. So let's start with the first question, and that is, so what is the most common presentation of these arrhythmias? The choices are PVCs, non-sustained VT, sustained ventricular tachycardia, or polymorphic VT and VF. Okay, so that's sort of a good answer. And most of you feel that premature ventricular complexes or isolated PVCs is the most common presentation, and that is correct. So then the second question is, I'm able to advance this page here, Nishant. Okay, so the distinguishing ECG features of left ventricular papillary muscle arrhythmias. Here are the choices: right bundle branch block morphology, lack of precordial transition, and left superior axis. Right bundle branch block morphology, lack of precordial transition, and an inferior axis. Right bundle branch block morphology, late precordial transition around V4, and the presence of an initial Q wave in lead V1. And then the last choice is a left bundle branch block morphology with early precordial transition. And typically, anything that transits by about lead V2 is considered early. So let's see what the group means. Okay, so again, some difference of opinion here, and obviously this is something that we'll talk about, so that's good to know. The third question is, during catheter ablation of papillary muscle ventricular arrhythmias, the target site, how do you identify that? And so the choices are, at the earliest site, you should see a sharp protruding potential during sinus rhythm, which also is seen during the ventricular arrhythmia. Second choice is that the site of earliest activation doesn't need to be a protruding potential, but it should precede the QRS complex by about 20 to 40 milliseconds. The third option basically says that choices 1 and 2 are both correct. And then the fourth option is that really we should use phase mapping and find an identical phase map match, and that should be the target site. And activation mapping is not as helpful. All right, so I think most of you got the correct answer, which means you have to find the site of earliest activation. If you find a Purkinje potential, that's helpful, but doesn't always have to be the case. All right, let's just go to the final question, which is, when discussing management options for papillary muscle ventricular arrhythmias, which of the following is the most accurate statement? So the first one is that papillary muscle ventricular arrhythmias are benign and they don't require any treatment beyond reassurance. The second option reiterates the point that they are benign, but allows physicians to use beta blockers or calcium channel blockers to treat patients. The third option advocates treatment for symptomatic patients or asymptomatic patients with a high arrhythmia burden, but the choice is preference for antiarrhythmics over catheter ablation as the first option, because catheter ablation is not very successful for these arrhythmias. And then the last option talks about treating highly symptomatic patients or patients with a high burden of arrhythmia, and advocates for catheter ablation as the first choice because it's quite successful. It's a lot to read, so I'm trying to respond. Okay, very good. Okay, so that's an interesting, response, and I think it's worthwhile, clarifying that issue. So I think that's great. So let's now build on this. So let's get to the meat of the matter. Right? So when we think about the papillary muscles, the way I imagine them, and I think that's really how these structures are. Basically, they are so-called complex pouching of the myocardial wall, and their primary purpose is to serve as supporting structures for the mitral and tricuspid valve. And so, because the mitral valve has two cusps and the tricuspid valve has three cusps, the left papillary muscle are typically grouped as anterolateral and posteromedial. The right ventricular papillary muscles, three of them, anterolateral, posteromedial, and septal. Now, the papillary muscle itself, obviously has an interface of the muscle with the Purkinje fiber network within them. And many believe that the arrhythmogenic potential of these structures is as a result of this interplay of neural structures within the muscular bundles. So in terms of the mechanisms underlying cardiac arrhythmias as they relate to papillary muscle, I mean, if you think about cardiac arrhythmias in just very generic terms, you can classify arrhythmogenesis into two broad categories. So there are the abnormalities of impulse formation, and those can be either abnormal automaticity or triggered activity. And then, of course, the second category of arrhythmogenesis is abnormalities of impulse conduction, which is another way to, basically define re-entry, how the impulse moves from point A to point B. So when you think about the papillary muscles and the Purkinje potentials and the Purkinje network within them, you can see how all of these mechanisms can potentially happen for the arrhythmias that arise from these structures. So the fact that you have neural bundles existing between muscle fibers in relative isolation, it can cause resetting of the resting membrane potential, which could promote automaticity. The same reason could also lead to abnormalities of repolarization, which can then lead to trigger activity. And certainly, if there is any disease process within the papillary muscles, which can cause delay in the conduction velocity, then that can actually also perpetuate re-entry. So all of these mechanisms can be sustained by the papillary muscles. And so it's not a surprise that when you look at the manifestation of the arrhythmias, you can have premature ventricular complexes, isolated PVCs, which generally are the result of abnormalities of impulse formation. Sometimes they can be isolated, sometimes you can have non-systemic. But then again, if the papillary muscle is capable of slow conduction, there's an infarct, which is not an uncommon territory where inferior and posterolateral infarcts of papillary muscles get involved, and that actually can lead to abnormalities of impulse conduction, and so you can have sustained monomorphic VT. And then we are all familiar with the arrhythmogenic potential of these structures that can actually trigger PVC-generated VF in polymorphic VT, and those have been well described even in patients who lack structural heart disease. And so, as a result of this diversity of the arrhythmia presentation, the patient's symptoms can also vary markedly. You can have a lot of patients who just show up, and the first time it's an incidentally recognized manifestation of the arrhythmia. They have a very high PVC burden, but they're totally unaware. But other times, patients may notice palpitations, depending on whether these arrhythmias are sustained. Sometimes they can cause presyncope, and certainly sudden cardiac death has been described, particularly in population of patients with mitral valve prolapse, where PVCs originating from the posteromedial papillary muscle have been at least invoked as one of the possible mechanisms. And then, of course, depending on the burden of the arrhythmia, even isolated PVCs, if the burden is very high, can certainly perpetuate cardiomyopathy. So the presentation of these arrhythmias can be diverse. So let's try to talk about the individual groups. And so broadly, if you think about papillary muscle ventricular arrhythmias, you can have the left ventricular papillary muscle ventricular arrhythmias, and then you can have the right ventricular papillary muscle ventricular arrhythmias. So we'll start with LV papillary muscle ventricular arrhythmias, because between the two groups, this is certainly the more common presentation. So the ECG features, and we had a question on this. So the papillary muscles are in the left ventricle. Anything that's coming from the left ventricle, unless it's extremely septal, should generate positive forces in the lead. And so, as a rule, papillary muscle ventricular arrhythmias originating in the left ventricle should have a right bundle branch morphology or positive forces in the now, remember, the papillary muscles are sort of mid-cavitary. You can have the extent of the papillary muscle that can go from the base, which is near the apical aspect of the ventricle, towards the tip, which is closer to the valves. But the entire structure still is somewhat mid-cavitary. And so anything that comes from the mid-cavity of the LV tends to have some precordial transition. The only time you lack precordial transition is if the source of the arrhythmia is basal, like on the mitral valve, which is not the case with papillary muscles. And so almost always you have some precordial transition. And typically, depending on whether the source is exiting near the base of the papillary muscle, then the precordial transition can be early, or if it is exiting closer to the tip of the papillary muscle near the chordae, then the precordial transition can be later. But there should be precordial transition. So those are the two unifying features. And then depending on whether it's the anterolateral or the posterior medial papillary muscle, there are a few features that are unique to those. So with the anterolateral papillary muscles, because it's situated somewhat higher up on the lateral wall of the LV, the inferior leads tend to have predominantly positive forces, but there can be some discordance between leads 2 and 3, where 3 may be more positive than 2. And then, of course, because it's a posterolateral structure, it tends to manifest negative forces in leads 1 and 8. Now, compare that to a posteromedial papillary muscle. There, the forces are predominantly superior. And so you will not find this discordance between the forces in leads 2 versus 3 if it's the posteromedial papillary muscle. Also, for the posteromedial papillary muscle, ventricular arrhythmias typically AVL should be positive. So something is coming from the bottom of the heart, it tends to travel somewhat equally to the right and the left shoulder. So AVR and AVL tend to manifest positive. So when AVL is negative, it's unlikely to become posterior impact. Now, people have obviously studied the unique features of ECG for these arrhythmias because it's important to differentiate them from other arrhythmias that can become the LV, such as the fascicular ventricular tachycardias, or ventricular tachycardias coming from scar within the LV, and certainly tachyarrhythmias that originate from around the LV ostium and the mitral valve. And so this is a paper that was just published by our group, and this is looking at about 100 plus patients with papillary muscle ventricular arrhythmias and comparing them to a control population of patients who also presented with predominantly right bundle branch blocking morphology VT, which is positive forces in V1, but not in the papillary muscles. And the control group was diverse. It included patients with fascicular VT, VT from the ostium, outflow tract, infravasal VT, and of course the apex. So one of the features that, and again, when you read through the literature, there are different criteria that people have used. The point of this paper really was, are there a limited number of leads that can allow you to make a quick diagnosis that yes, with some certainty that it's a papillary muscle arrhythmia. So one of the features that stood out is the morphology of the QRS complexes in lead V1. And so there are three types that were found with papillary muscle ventricular arrhythmias, and those are shown here. First couple is where you actually see a clear R small notch and R prime, where the R prime is shorter than the initial arm. And this is what has been described as the rabbit ears and other ECG patterns, but this is one manifestation. The second manifestation is where you don't quite see this RSR prime pattern, but you see some slurring on the downstroke of the QRS complex in lead V1. It's predominantly positive, of course. And then the third morphology is where both the peaks, R and R prime, are about the same height. Now compare that to the rest of the PVCs, which are shown in the slide here, where you'll see that none of them actually have any of these, whether it's an RSR prime or the slurring. So that was lacking in this group. So amongst the 111 patients in the control group, only 2 of them had anything similar to this. But all the patients in the papillary muscle group had this sort of manifestation. That stood out as being almost pathognomonic of this particular category. Another thing that we looked at was the time that it takes from the beginning of the QRS to reach the first peak. And this was typically much shorter for papillary muscle than the remaining control group population. And you could actually use a cutoff value of 74 milliseconds to reach the first peak of the intrinsicoid deflection in V1 as being the cutoff that you could use to separate the two. So putting it all together, these are some of the different things that we looked at, and the ones that stood out, of course, the time to intrinsicoid deflection, which if it's less than 74 milliseconds is highly predictive that it's coming from the papillary muscle. And another morphologic feature that was interesting is the presence of a small Q wave initially in V1, which was seen in 75% of the papillary muscle ventricular arrhythmias, which you could still see in about 25% of the non-papillary muscle ventricular arrhythmias. So it was not as defined. So to summarize the ECG features, some folks have commented on the QRS duration, which for papillary muscle ventricular arrhythmias is typically longer than fascicular, but in our paper that I just shared with you, other than the fascicular VTs, the rest of the LV VTs have a similar QRS duration as the papillary muscle ventricular arrhythmia. So it's not very discriminating. Precordial transition, we talked about that. If it's beyond V4, It is associated with this group, but it's again not diagnostic. Inferior lead discordance is helpful in distinguishing anterolateral from posterior medial papillary muscles. Presence of a small QA in lead V1 is also seen in a lot of these. But again, the distinguishing features are the presence of this particular morphology that I showed you in lead V1, where it either has an R prime, which is smaller than the initial R, or the same height as the initial R, or slurring on the downstroke. That had a sensitivity of 93% and specificity of 98%. Intrinsicoid deflection in lead V1 of less than 74 milliseconds, that also had a very good specificity. The sensitivity was not that great. But again, these two together can be helpful in discriminating papillary muscle ventricular arrhythmias from the rest of the pattern. Okay. So now moving on to what we can expect when we try to ablate things. So a few things about the papillary muscle itself. Obviously, it's an intracavitary structure, so it juts out within the cavity of the left ventricle. Even though we think about papillary muscles as having a fairly well-defined anatomy with two heads for each of the papillary muscles, this is actually not always the case. The anatomy itself can be variable, the thickness can be variable, and they are contractile structures, so they're fairly dynamic, and so they sort of are hard to really balance your catheter and map. And then, of course, depending on how dense the network of the Purkinje network is and how diseased it is, you can have changing exits of the arrhythmia through this dense network. And of course, the mechanism of the arrhythmias can be variable. So there are a lot of potential challenges when you try to go after arrhythmias originating from the papillary muscles. And consistent with that, our evolution of the techniques has been sort of a work in progress. And so very early on, when we first started recognizing these arrhythmias, we sort of stumbled on it. So what I'm showing you here is a patient that I ablated in 2006, I believe. And if you look at the morphology based on what we just discussed, yes, it looks like it's coming from the anterolateral papillary muscle. But in those days, we weren't even aware that this structure was capable of arrhythmogenesis. We just expected this particular arrhythmia to be coming from some location in the mid-posterior LV, just based on the QRS morphology. And you can see the quality of the X-rays that were available to us were really not things that we have now. And with the limited mapping points on the electron-atomic map, it looked like there was something coming from the mid-lateral LV. And sometimes you get lucky, and in this particular case, we found like this really, really early potential sharp preceding the QRS by about 40 seconds. We were successful here. But then again, as you go through some of these cases, it dawned on us. Like, for example, this is another case where we have localized the source of this particular PVC, which again looks like it's from the anterolateral papillary muscle with the knowledge we have now. But at that point in time, we thought this was in the mid-lateral LV. But the interesting thing about this particular location was that when we had our catheter in that position, we just could never get the tip of the catheter out to the silhouette of the heart on an LAO projection, which is what made us think that there is this structure that's prohibiting us from getting to the wall itself. And yes, obviously we all know about the papillary muscle, but sort of stumbled upon the arrhythmia source. And then we kind of get innovative in mapping. So this is an example of how we first started mapping these structures, where using point-by-point mapping, we first create the LV shell. And then within the LV shell, we do point-by-point mapping using basically fluoro to sample different parts of the papillary muscle to create a structure within the cavity of the LV. And then doing that, now you can see you have a little bit more structure to the papillary muscle, and you can now identify an area of relatively early activation. We can see how challenging this whole exercise is if you use X-ray to guide yourself to creating an intracavitary structure. and a lot of fluoro exposure. These procedures took a lot of time, and in that period, which is either the pre-ICE era or early ICE era, the success rate that most of us had in tackling these arrhythmias was really not that great. So this is a paper from the group in Alabama, Dr. Yamada and colleagues. They did some of the early work in this particular area. And they defined in a small series of 19 patients, half of them from the posteromedial papillary muscle, half of them from the anterolateral papillary muscle, kind of talking about some of the observations. Sometimes you find an early potential, sometimes you don't. Sometimes you find a good pace map, other times you don't. But the bottom line is that single procedure efficacy in these small series for catheter ablation was about 40%. And that was, shared experience. So this is the early success rate of papillary muscle ventricular arrhythmia ablation of pen. And you can see that from 2007 to 2010, these are really not good outcomes. But then in 2011, you'll see here, as I've shown the slide, there is doubling of our success rate. Well, what was the reason for that? Turns out that somewhere around that era, we started using ICE a lot more consistently for all our ablations. And in doing that, we were able to really appreciate sort of the intracardiac anatomy and the disposition of the papillary muscles, and so refine some of the structural characteristics, which then allowed us to be a little bit more accurate in positioning our catheters and sampling the structure. And with that, we were able to define a little bit better the site of origin of the arrhythmia. So this is just an example of what ICE can do for you. So here are two cases of an arrhythmia that was targeted from the anterolateral papillary muscle. And you'll appreciate that in the first example, the catheter, you can see it coming through and going under the anterolateral papillary muscle, and it's extending into the depth of the papillary muscle, pretty much near the base of the structure. In the second example, again, it's an anterolateral papillary muscle with two heads, but this time you can appreciate how this catheter is resting on the body of the papillary muscle, so just on the top of the superior. So this is what ICE was able to allow us to do, really refine mapping techniques relative to the complex case. The other thing that we were also able to do with subsequent iterations of ICE technology is the ability to actually use ICE to segment the cardiac anatomy. And for a variety of arrhythmias, this has now become sort of our standard approach. It didn't used to be that, but for the papillary muscles, you can see how ICE segmented anatomy can really allow you to identify unique features. So here is sort of the classic textbook representation of the anterolateral and posteromedial papillary muscles, and both of them have two heads, which you can identify. You can define the apex of the papillary muscle, the tip of the papillary muscle, the body of the papillary muscle. And doing that with ICE segmented anatomy allowed you to do this actually very quickly. Now think about trying to do this using fluoro and doing point-by-point mapping to characterize the structure versus ICE. It literally takes you 1/10 time to do it, and you have a much better representation. And then finally, the advent of contact force sensing technology then allowed us to really gauge just how well or poorly we were doing in achieving contact of our catheter with the structure. So here are two examples. The first one you can see is where a catheter is resting on the body of the PAP. The vector is sort of really not doing much, and you can see the contact force here is about 3 to 4. So when you go on here, you know that the lesion that you're creating is really not that great. Here's a second example where you can see the catheter is stuck under the papillary muscle. The vector is pointing upwards. And the kind of force that you're generating here is so much better. And you know that for this particular lesion, if you are on the spot where the site of origin is, it's more likely to be successful. So those are some of the technological innovations that have really allowed us to do a better job, and that reflects in outcomes. So this is now the cumulative experience of PEN all the way to 2017, and you can see the early experience where our success rates were not that great, and then the advent of ICE mapping to refine our ablation technique, and you can see there's a doubling of the success rate. And then around 2015, we started incorporating some of the other tools that I shared with you, including ICE segmented anatomy together with contact force mapping. And you can see now the success rate. So this is single procedure drug-free survival after ablation. We're getting into the kind of numbers that allow us to advocate for catheter ablation as being the first choice for people in this movement. So we are seeing this now, but it's been a long and arduous process to get to where we are. And this is not our experience alone. So this is a small series that comes from a group in Argentina, about 50 some patients. And they looked at the success rate for papillary muscle ventricular arrhythmias in 3 different scenarios. So one group of patients was treated using contact force sensing and ICE segmented 3D anatomic mapping, kind of what I showed you in the previous slide. There's another group of patients where they actually used cryoablation after contact force mapping was not able to get the arrhythmia. And then the third group is where they did everything that they did in the group in red, but instead of contact force sensing, they had non-contact force sensing catheters. So you can see that there is a significant difference in the success rate of the procedure, where for the non-contact force sensing group, these are half as successful as the other two. And this is somewhat similar to our experience, but those are the kind of success rates that we are looking at. So this is our most recent outcome analysis all the way to December of 2019. And this is 137 patients, where about 70% of whom were done using contact force sensing. And for these patients, our overall success rate, both in terms of acute procedural success, it's about 95%, and clinical success was upwards of 85, almost 90%. So that is sort of our experience using all the tools that I just shared with you in terms of what we're able to accomplish. Now, interestingly, for our